Sir Vince,
Yes, po.
can start.
Okay.
Sir Vince, you can start. Thank
Yes.
you.
Good afternoon, everyone. It is my pleasure to welcome you all to today's international webinar on integrating medicine and science in sports, injury prevention, and rehabilitation, organized by the International Association of Physical Education and Sports. Who are we? The International Association of Physical Education and Sports, founded in Thailand in the year 2009 and registered in Thailand and Philippines with the tagline, "We shape the world of physical education and sport." My name is Vince Rabang, your moderator today. But before we go any further, I'd like to remind everyone to keep your microphone muted in order to prevent unwanted background noise from distracting the speaker and other participants. Second, all your questions and clarification will be entertained after the talk of our speaker. To begin formally, let us begin with the prayer, followed by the singing of the national anthem of Malaysia, Thailand, and Philippines.
Our Heavenly Father, the fount of all goodness and grace, the cause of wisdom, the source of intelligence, we welcome you, O Lord, to this auspicious gathering of your beloved, who continuously give you thanks for every opportunity to learn something new and become fruitful to the works of your creation. We humbly come to you, not because we are worthy, but because we find ourselves in need of you, who is our strength and our hope, to continue despite the challenges we face in health, prosperity, and our solidarity with one another. We pray that today's gathering, made possible by the grace of advancements in technology and social media, becomes successful in its endeavors, so we can offer it back to you as our humble offering to honor you, glorify you, and love you through our deeper connection with everyone. May we find bliss in today's session and become more productive children and co-creators of the earth. This we ask and pray through Christ our Lord. Amen.
ธงชาติและเพลงชาติไทยเป็นสัญลักษณ์ของความเป็นไทยเราจงร่วมใจยืนตรงเคารพธงชาติด้วยความภาคภูมิใจในเอกราชและความเสียสละของบรรพบุรุษไทย
Mga kababayan, ang pambansang awit ng Pilipinas. Kayang magiliw, pero sa silanganan, alam ng puso, sa dibdib mo'y buhay. Lupang hinirang, kuya ka ng magiting, sa manlulupin, di ka pasisingil, sa nagatak tutok sa simoy at sa langit mong bangaw, ay hinatang tulad, awit sa pagkayang minamahal. Ang isang ng matawad mo'y tagumpay na nagtitindig, ang bituin at araw niya kailan pang ay di magtitindig. Lumang ang araw ng walhagit pagsinta, buhay langit sa piling mo. Ang inigaya na pagkay mga api, ang mamatay ng dahil sa'yo.
Service.
Ayun. Okay, I'm sorry. Rehabilitation after a sports injury has evolved into a specialty in the modern era, which will need the collaboration of a sports physiotherapist, a sports physician, and an orthopedic surgeon. Modern rehabilitation protocols emphasize teamwork and proper rehabilitation planning, and the rehabilitation team has to be led by a trained sports physiotherapist with an understanding of the protocols and intervention required at various stages. Injury-specific rehabilitation protocols are being practiced worldwide but need to be introduced according to the nature of sports. May I call in Associate Professor Dr. Jiwason M. Santos, the President of IAPES, for his inaugural speech.
Sports injuries often occur during sports participation, training, and competition. To decrease sports injury occurrence and enhance injury recovery, in order to return to play, are the care goals for injured athletes. Many special prevention strategies in sports rehabilitations, such as nutritional or medical supplements, acupuncture, massage, instrument assisted soft tissue mobilization, vibrating foam roller, low-level laser therapy, cold water immersion, kinesiology tape, and etc. are used in the field of sports injury prevention and rehabilitation. With an increasing number of people participating in exercise, innovative application on prevention strategies and sport rehabilitations may improve the recovery of the injured tissue or increase the fatigue recovery of an athlete. In many cases, this application should not be only focused on the effects of sports injuries, but also on the management of the primary cause of injury. Exercise is good for the body, and with proper precautions, sports injuries can be often prevented. The quality of protective equipment, such as padding, helmets, shoes, mouth guards, has helped to improve safety in sports, but you can still be susceptible to injury. Always contact your healthcare provider before starting any type of physical activity, especially vigorous types of exercise or sports. Sometimes here are some of the causes of sports injuries, which may include improper or poor training practices, wearing of improper sporting gear, being in a poor health condition, and incorrect warm up or stretching practices before a sporting event or exercise. Common sports injuries may also include sprains and strains, joints injuries, muscle injuries, dislocations, fractures, Achilles tendon injuries, and pain along the shin bone. For us to properly understand and prevent injuries, these are some simple ways that you can follow. Develop a fitness plan that includes cardiovascular exercise, strength training, and flexibility. This will help decrease your chance of injury. Alternate exercising different muscle groups, and exercise every other day. Cool down properly after exercise or sports. It should take 2 times as long as your warm ups. Stay hydrated because when you drink water, you prevent dehydration, heat exhaustion, and heat stroke. Stretching exercise can improve the ability of your muscles to contract and perform, reducing the risk of injury. Each stretch should start slowly until you reach the point of muscle tension. Stretching should not be painful. Always um, look onto that. Aim to hold each stretch for up to 20 seconds. Use the right equipment or gear and wear shoes that provide support and that may correct certain foot problems that can lead to injury. Also, learn the right techniques to play your sports. Rest when tired and avoid exercises when you are tired or in pain. Always take your time during the strength training and go through the full range of motion with each repetition. And if you do sustain a sports injury, make sure you participate in an adequate rehabilitation before resuming strenuous activity. I would like to take as well to take this opportunity to our resource speaker, who will be as well properly introduced later, for giving us the opportunity to learn from his vast experience. I would like as well to thank the members of the organizing committee for rendering their time and effort for the conduct of this timely webinar. And most especially to the participants who have given their precious time to be with us and participate on this timely webinar. With that, thank you and have a pleasant day ahead.
Thank, thank you, Dr. Jewel, for enlightening us regarding sports injury and rehabilitation. Now, let us all hear Associate Professor Dr. Kishore Mukhopadhyay, Associate Professor, Union Christian Training College and Chief Advisor, IAPES, for his introductory address.
Hello, may I audible?
Yes, sir.
Okay. Today's international webinar on integrated medicine and science in sports injury prevention and rehabilitation organized by International Association of Physical Education and Sports Incorporated. I wish good morning and good afternoon to all, depending upon the respective geographical locations. Respected Dr. Joelson M. Santos, our young, energetic, and hardworking President, International Association of Physical Education and Sports Incorporated, for giving me the opportunity to deliver over here as an introductory speaker. My fellow friend, Mr. Subroto De, member of our esteemed organized association, today's resource speaker, Dr. Alston Choong Y Kon of University of Malaya, Malaysia, Professor Arjerin, Mr. Lemuel, Mr. Lukto, Mr. Vincent, and ladies and gentlemen. So today's webinar is a combination of sports medicine as well as rehabilitation in connection with sports injuries. Actually, sports medicine is a multidisciplinary concept, including physical, physiological, biomechanical, and pathological phenomena associated with exercise and sports. It deals with three main aspects: athlete and his or her environment, first one. Next one, prophylactic healthcare, and third one, sports medicine service. Under this athlete and his environment, there are various areas are there: physiological areas, then biomechanical areas, nutritional areas, psychological areas, and training areas as well. In the prophylactic healthcare, it is dealing with the maintenance of fitness, detection of disorders, functional evaluations, delaying of aging, and health education for sports persons. In sports medicine service, there are two aspects, as I think so, three important aspects. First one is the preventive aspect. Our learned President, Dr. Joelson M. Santos, had throws his light and insight on this preventive aspect very nicely. So I am not going into this area. Then next one is the management aspect, sports injury management. And this sports injury management can be done in two ways. First one is the immediate management, and second one is the treatment. Immediate management, it deals with the first aid aspect of an individual. For doing immediate management, for imparting immediate management to an injured sportsman, first, it is the duty of a sports medicine specialist to assess the condition of the athlete with the help of TOTA phase principles and ABC principles as well. Then it is the time to the initial treatment stage. This initial treatment stage can be easily managed with the help of Pricer and police principle. And the last phase is directed toward the rehabilitation phase, which is a part of physiotherapy. So first one is the sports medicine aspect, and the last one is the physiotherapy aspect. And these physiotherapy aspect, there are so many modalities are there depending upon the electrical and ice, hot, etc. The basic principles of these therapeutic modalities are depending upon two aspects. First one is the cold aspect, and second one is the heat aspect. And these two are penetrating our deep tissue to work properly. Either with the help of cold, we can create vasoconstriction, or with the application of hot, we can able to create vasodilatation of the deep tissue. And we should remember that cold has a much deeper penetrating power than that of the hot counterpart. And cold has two effects. First one, localize the injured area, stop the spread of the injury. And the second one is local anesthesia effect. So these two are the main important aspect of this physiotherapy. And depending upon these principles of hot and cold, there are so many gadgets are there. It can be a vibrator, it can be an electrical stimulator, it can be a ray, it can be a hot water, it can be a cold water, so on, and cryotherapy, so on. So what is rehabilitation? Rehabilitation is the restoration of optimal, that means anatomical, and functional, that means physiological. The rehabilitation as a process targeted at minimizing the loss associated with acute injury or chronic diseases to promote recovery and to maximize the functional capacity, fitness, and performance within the shortest possible time. Now, tissue injury from sports can be classified in so many ways. I just want to mention two areas as well here. First one is the macrotraumatic, and second one is the microtraumatic. Macrotraumatic injury are usually due to strong forces, and these injuries can be primarily due to direct tissue damage. And microtraumatic injuries are chronic injury as the result of overuse of a structure such as muscle, joint, ligament, tendon, and so on. The ultimate goal of rehabilitation process is to limit the extent of the injury, reduce or reverse the impairment and functional loss, and prevent, correction, or elimination altogether the disabilities, and make the ultimate capacity of an individual. There are 7 principles in rehabilitation, which we can memorize it as a ATC ISIT. ATC is ISIT principle. A means aggravation of injury. When we are dealing with the second aspect of the physiotherapy, that is the exercise therapy part, we should keep in mind the range of motion aspect. There are AROM, assistive range of motion, PAROM, progressive range of motion. All these things are there in the exercise principles. So while treating the injured after treatment, while promoting the exercise therapy, we should keep in mind that injury must be reduced, not to aggravate it. Next one is the timing. What time is appropriate for starting the rehabilitation program? It is prescribed that as early as possible, the rehabilitation program should be administered. Otherwise, it will be delayed to recovery, complete recovery. So the time span we will require more to reduce the pain or reduce the disabilities of an individual. Then compliance is an important aspect. For complying goal settings, including athletes in decision-making work as a motivational factor to continue the rehabilitation process. Motivation is a must. First of all, we have to counsel the athlete before going to start the exercise program. Then we have to follow the principle of individualized method. No two individuals in the world are equal. Everybody has some different aspects. So depending upon the individualization, there is no fixed pattern to follow. We have some guidelines as well. So depending upon that guidelines, this individual consideration we should keep in mind while promoting this exercise therapy. Then the specific sequencing, the exercise sequencing should be proper. It should be proper in sequence so that no harm can be occurred. Then intensity must be slow, then moderate, and the last stage must be high. Intensity should be in a progressive manner. Don't start high intensity activity in the beginning. And we have to, then one key aspect is there, that is we have to consider the athlete or the sportsman as a total patient. Because if the injury is occurred, if we are administering some sort of exercise therapy in the right hand, at the same time, the performance of the left hand is reducing due to inactivity. So keeping the point of mind of the totality of an athletics physiological and anatomical position, we have to deal the total aspect of an athlete by promoting the bilateral transformation principles so that the other component, the capacity of the other part of the body may not be reduced. Then what are the component of this physiotherapy, rehabilitation exercise therapy? First component is the pain management, then flexible and joint ROM, then stretching and endurance, then proprioception and coordination, neuromuscular coordination so that they can do some sort of activity within a shortest possible time. They can maintain their balance. All these things are there. Then functional rehabilitation. All these are the important aspects of the exercise therapy. use the bilateral principle to maintain, as I earlier told, the optimum capacity of the injured body part is an important aspect of sports injury rehabilitation. And the last stage, when your athlete is totally fit, you have to monitor whether his performance level is well up to the level in the ground or not. If not, what is the cause? And always keep in mind that the rehabilitation program should be as short as possible. That means our target is shortest possible recovery, so that he or she can able to enter in the sports arena within a shortest span of time. This will make him more capable to maintain his normal fitness level. Otherwise, his fitness component may be deteriorate in a greater extent. So with this word, I express my thanks, and I hope all the participants will learn a lot from this international webinar. Thank you, everybody. Have a great day, and wish a grand success of today's international webinar. Thank you very much.
Thank you, Dr. Kishore. At this point, may I call in Mr. Subatsa Day, member IAPES, for his welcome address.
Hello, can you hear me?
Yes.
Yeah. So very good morning from India and good afternoon all my respected participants over there. This is Subrata Day on behalf of IAPES, International Association of Physical Education and Sports Incorporated. Once again, we are here today in international webinar on integrating science and medicine, both for the prevention of injury and rehabilitation program. It is indeed my great pleasure to welcome all of you here, our respected Honorable President for IAPES and Chief Advisory Board Member, Professor Sir, for here, and all my respected participants. As you know, that medicine and science, this is one of the important area in particularly modern sports. And injury, of course, this is one of the part and parcel of an athlete's life, and we must have to take care about the prevention and management, as some of the points Professor Mukhopadhyay has elaborately told about what is important. And today we have, for our technical session, we have our eminent speaker, Dr. Alston. I think he is the right person to explore, to share his knowledge to all of you here. And without taking much time, I once again, on behalf of IAPES, sincerely welcome and thanking for joining with us, particularly for this webinar. So let us enjoy and let us learn from our today's technical session expert. So once again, I also welcome our today's expert, Professor Alston, for being with here, and let's enjoy our session. Thank you.
Thank you, sir, for your warm welcome. Now, it is my honor and privilege to introduce our speaker. He is a sports and exercise medicine physician in the University Malaya Medical Center, Kuala Lumpur, Malaysia, medical lecturer of Sports Medicine Unit, Faculty of Medicine, University of Malaya, and Honorary Vice President of Malaysian Association of Sports Medicine. Let us give a warm welcome to Dr. Alston Choong Y. Choong. Sir,
Hi, a very good afternoons to everyone, especially to Prof. Jeffersons for the kind invitations to me to give the talks today on integrating medicine and science in sport injury and preventions and rehabilitations. Okay, I would like to start my slide, share my slide first. Okay, can you see my slide?
Yes.
Okay, a very good afternoons again to all the audience, and very thanks very much for Prof. Jefferson for giving me this opportunity to present the topics of integrating medicines and science in sport injury and preventions and rehabilitations in the international webinars organized by the International Associations of Physical Activity and Sports, and also Sport Incorporated Philippines. Okay, first and foremost, let me introduce myself. I'm Dr. Alston. I'm actually graduated from University Malaya, and I'm the sport and exercise medicine physicians practicing in University Malaya Medical Center. I'm also currently the medical lecturer in the University of Malaya. On behalf of that, I'm the Vice President of Malaysian Associations of Sport Medicines, and I'm also holding the post as a research member of the Sport and Exercise Research and Education Group in the university. Okay, so the topics that I will cover for today include the sport injury preventions and also sport rehabilitations. So basically, it's very huge topic to cover, but I will try my best to finish within an hour, probably slightly more than an hour. Okay, so the content that I will cover for sport injury preventions includes the importance and level of sport injury preventions. Next, we will look into the conceptual approach on sport injury preventions, include the 4-step models, the TRIMS frameworks, the REAIM frameworks, the injury causations models, and then we will look into what are the components of sport injury prevention programs, which include the training strategy, the neuromuscular trainings, the sporting rules, the protective equipments, and also the appropriate surface during sporting activities. Okay, and then we will look into the step to promote adherence of the athletes and also the team to adhere to the sport injury preventions programs. And then we look into the individual some of the common musculoskeletal injury on the preventions, on how to on the prevention, and also the risk factor on hamstring strain, ankle sprain, acute knee injuries, and overuse injuries. Then we will move to sport rehabilitations, the definitions, and also what are the important components on a sport rehabilitations program. And there's this sport rehabilitations umbrella, which I will explain further later. And then the principle of sport rehabilitations. And then we will go into the fundamental components of a sport rehabilitations program. Then we move into the 5 phases of a sport rehabilitations, and then the progressive model that we usually use in a sport rehabilitations. And last but not least, I will touch a little bit about the START framework for return to play. Okay, so as we know, so we will start with sport injury preventions. The importance of sport injury preventions includes as we know, the sport participations is encouraged as it has numerous positive effect. Okay, and there is a significant burdens of sport-related musculoskeletal injuries, especially in youth and also in young adults. So the primary injury prevention is important and should be prioritized to avoid these numerous implications. Okay, and the implications of the sport injuries is not just on physical implications. The long-term physical implications, example like the early onset of post-traumatic osteoarthritis, adhesive capsulitis, and also many other physical implications can also occur. Beside the financial complications, beside the physical complications, the financial complications such as the treatment costs, the time lost from work for recreation player, and also time lost from play for professional athletes is also prominent. And when the individual have a sport injury, sustained sport injuries, there is the increased prevalence of overweight and obesity because of drop out from the sport because of the injuries or fear of re-injured. So in Australia alone, the direct cause of sport-related injuries over a 7 years period amount to be an estimated 265 million Australian dollars. And lower extremities injuries are the highest overall burdens of sport-related injury at about 60%, of which 60% are ankle and knee joint related injuries. Okay. So the level of sport injury preventions basically can be divided into three, which is same like all the public health illness preventions. Okay, in sport injury preventions, we can actually divide it into the primary preventions, which is synonym to prevention itself, which means the prevent the injury before it ever occur, include health promotion, injury preventions. And then the example of the primary prevention would be like wearing an ankle brace, okay, by the entire team, regardless of whether the athlete is injured or without injuries, okay. So the secondary preventions will be synonyms to treatments, okay. This actually means early diagnosis and interventions to actually limit the development of disability or reduce the risk of re-injuries. And examples of secondary prevention will be early treatments of ankle sprains to prevent the ankle to become worsens and evolve into the complications such as a chronic ankle instability. And then the tertiary preventions, which is synonymous to rehabilitations, is actually mean focus on the rehabilitations to reduce and correct an existing disability attributed to an underlying disease. Okay, example of these tertiary preventions is imagine a patient with ankle sprain. We will actually refer the patients to the physiotherapy for therapeutic exercises, and then the exercises will include the balancing and the proprioception exercise and gradual return to play after the initial treatment of the ankle sprains. Okay. So now we move to the important conceptual approach about this sport injury prevention. The first approach that I want to introduce is the 4-step models. Okay, these 4-step models is actually introduced by Van Mechelen in 1992, and he actually developed the 4-step models for injury prevention in sports. And this model has been the foundations for the development and evaluations of injury preventions. The step 1, okay. The step 1 actually is the establishing the extent of injury or problem in a specific populations through surveillance system and describe it in terms of the incidence and severity of the sport injury. Example, if you are a team physician that responsible for a team, this actually involves recording all the injuries within the team as well as during the trainings and match exposure. Step 2 is identify the etiology and also the risk factor and mechanism for injury in which in a specific populations. For examples, like as a team physicians, this involves the systematic step to examine the athletes and their training programs and competitions. And step 3 will be development of the validations of injury prevention measure or strategy based on the etiology and mechanisms of injury identified in the second step that I mentioned just now. And the last step, step 4, is implementations of these injury preventive measures and evaluate their effectiveness or the efficacy by measuring the impact of the preventive measures on the incidence of injury using the appropriate surveillance systems. Okay, so various study design are used to investigate the effectiveness of injury preventive measures. Although the randomized control trial is the gold standards, it is not always possible or ethical. Therefore, a less rigorous study design, such as quasi-experimental, cohort, or even case control study are also being used. As a result of that, there are usually some methodological limitations that do introduce bias and thus limit the interpretations of the study to some extent. Okay, so for a team physician, continuously surveillance of the injury pattern within the team will reveal whether there are any changes occur in terms of the injury rate. Okay, next I would like to introduce the second frameworks or second models, which is what we call the TRIMS frameworks. So the best injury prevention program is the one that can and will be adopted and sustained by the athlete, coach, and also the sporting body. So there's no use if you have a lot of science, a lot of models, frameworks, but it's not practical and not being adopted by the sporting body or the coach or the athletes. So this framework actually emphasize to incorporate the science behind and then translate into the real world models. Okay, so some of the bigger challenge of injury preventions research is too laboratory based, high implementation costs, and not sustainable and not practical in the real life circumstances. So knowing the importance to address this challenge, Finch has come out with this TRIM framework, which is called the Translating Research into the Injury Preventions Practice. So what is actually TRIM frameworks? Okay, so TRIM frameworks is actually the combinations of, it's actually the extensions of Van Machelen's 4-step models, okay, which I described just now, and also include 2 additional steps that are necessary for the translations of the effectiveness of the injury prevention measure into a real life scenario. So the 2 additional steps includes the step 5, describe the intervention context in the real life to inform the implementations measure strategy, and step 6, the implementations the preventive measure or strategy in the real world and evaluate the effectiveness and also the efficacy. Okay, so the TRIMS framework is actually the extensions of the 4-step models. Okay, the third models is actually the RE-AIM framework. Okay, another framework that has received increased attention in the context of sport injury preventions is the RE-AIM frameworks, which mean the reach, efficacy, adoption, implementation, maintenance. Okay, this framework actually originally developed to investigate the impact of health promotion interventions. And this framework actually describes 5 steps to translate research into action. The first step is to reach the target populations, and then to make sure it's the action, the program is effective and efficacy, and then it has to be adopted by the target populations, okay, and then to implement consistency, taking account into the cost, and also adopt and adaptations made during the delivery. And the last one is to maintain of interventions effect in individual and over the time. Okay, the last model that I want to introduce is a little bit complicated, but this is the I think this is the most practical, and although it's sophisticated, but it's actually uh, is very is commonly is quite famous and is being adopted in by many team physicians. Okay, so this model is called the injury causations models. The team physicians that wants to prevent sport injuries in a systematic ways could base their approach on these comprehensive injury causations models by Mulvey et al. To describe the potential causative factor to injury. So these conceptual models was then expanded by Bart and Crowhart, illustrate the multifactorial nature of the sport injury, emphasizing the relationship of intrinsic, okay, the intrinsic and also the extrinsic risk factor to injury mechanisms. So the intrinsic risk factor, which is the athlete-related risk factor, is the factor which may predispose or protect the athletes from injuries, and this include the athlete's characteristic such as age, the athlete's maturations, gender, body compositions, and fitness level. One factor that consistently has been documented to be significantly predictor regardless of type of injury is the most important one is the history of previous injury. Okay, that is for intrinsic. Okay, so okay, intrinsic factor can also be subclassified into modifiable and non-modifiable. Modifiable risk factor may be targeted for changes, example, fitness level, through specific training methods, or the non-modifiable risk factor, example, gender, can be used to target intervention measure to those athletes who are at risk of injuries. Examples, we know like non-modifiable intrinsic risk factor. One of the common one for ACL injury is female gender. So probably the coach have to be have a specific injury prevention programs that cater the female footballer. Okay. Now we look into the extrinsic risk factor. Okay, in extrinsic risk factor, also called the environmental related risk factor, is the factors in which the athletes are exposed, such as flow frictions in the indoor team sports, the snow condition in alpine skiing, slippery running track, extreme weather, either very cold or very hot, and sometimes also related to the footwear. Okay, in the same way as intrinsic factor, the extrinsic factor may increase the risk or protect or reduce the risk of injuries. Okay, example, increasing risk is like if the athlete wear appropriate footwear, okay, then probably this will reduce the risk of the injury. If let's say the athletes running barefoot, okay, then this will probably increase the risk of injury. Okay, exposure to such extrinsic risk factor may interact with intrinsic risk factor to make the athletes more or less susceptible to injuries. when intrinsic and extrinsic factor act simultaneously, the athletes may be at far greater risk of injury than when risk factors are present in isolation. Okay. Also note that the risk factor, both intrinsic and extrinsic, um, are usually not static, okay, and can change over time and can even change during the training over one training sessions. Example, if the uh, athletes experience started to become fatigued, then probably that will actually change the intrinsic and also the intrinsic risk factor. Okay, now we look into the inciting event. Okay, inciting event usually refer to the injury mechanism or account for the events leading to the injury. Example would be the playing conditions, playing situations, the player or the opponent's behavior, and also include the whole body and also joint biomechanical descriptions. Okay, now we look into the sport injury prevention programs. Okay, we know that sport injury prevention program can reduce the number of injury as well as the severity and the extent of the injuries. Okay, so the four main area where injury prevention in sport is focused on are first the training strategy. Okay, the second one is the sporting rules and the policy change. And then the third one will be the protective equipment, and the fourth will be the appropriate surface. So I will further elaborate each of these later in my presentations. So training strategy should focus on modifiable intrinsics, risk factors such as interventions to improve the strength, endurance, and balance through neuromuscular training. Extrinsic risk factors are targeted through rule modifications and also equipment recommendations. Example, body checking in youth ice hockey, using an ankle brace, and then cricket player wearing a British standard compliance helmet when batting, wicket keepings or fieldings close to the battles. Okay, moving on, we will look into the factors that determine the feasibility of a sport injury prevention programs that actually includes the sport participants age group, the layer of plays, the type of sport, and also the organizational structure in which the original interventions was evaluated. Okay. Okay, now we move on to the fourth key step to actually promote adherence of either the athletes and also the whole team to follow the injury prevention program. Okay, so there are many factors influence the adherence to interventions that will maximize the effectiveness of a specific sport injury prevention program. So this is necessary to create a good balance between the evidence and also the real-world implementations throughout the development and evaluations of the interventions and to alleviate the problems of poor adherence. So Owe in 2018, in 2018, described that there's these four key steps towards a more rigorous approach that may promote the adherence to sport injury prevention programs. So the first one is actually the identify the adherence rates. So if the adherence rate is low, then we will need to determine what is the predictor that that actually the predictor for the low adherence and also or the non-adherence. Okay, and then we after identify the predictor, we need to develop a strategy to cater to improve the adherence rates. And then the last one, we have to evaluate back the effectiveness of our strategy that we already developed. Okay, and then the cycle your cycle will repeat back. Okay. Okay, we move to the other components of important components of the sport injury prevention program. Okay, the prospective study often investigate neuromuscular training injury prevention program in team sport with attentions toward amateur and also elite athletes, which include adults and youth. Okay, these programs are often led by the coach and trainer, and after a comprehensive training workshop by a physiotherapist or strength and conditioning specialist with the relevant expertise. Neuromuscular training prevention program do reduce the risk of injury as seen in various study. Okay, in youth study such as football, handball, basketball, there is a 97, according to a study, there is a 97% reduction in lower limb injury risk was reported. Other studies that investigate the protective effect of exercise interventions as method to reduce the risk of injury show that there's 37% reductions in overall injury risk and a 74% and a 74% reduction in 47% reduction in overuse injury risk. Okay, and an even greater preventive effect is reported when neuromuscular injury prevention program is concentrate on first the proprioceptions, balance, and also the strength. And they didn't see, the study actually found there's no preventive effect if seen with intervention that only focus on stretching. Okay, so this is important when you want to design a sport injury prevention program. Make sure you actually incorporate the proprioception, balance, and also the strength. Next, I want to show you a video. I hope this is play. Okay. Can you watch the video? Can you see the video?
Yes, sir.
Okay. So this is actually a neuromuscular training program by one of the UEFA football teams. Okay, as you can see, they are doing a very, I would say, simplified but effective neuromuscular training that involve the upper body. Okay, as you can see, the player over here by using the by doing the okay, there's this upper body. Okay, some of them doing the lower body, the lunges. Okay, and this will involve the upper back. Okay, and then this will involve the lower limbs. Okay, and then this actually involve the agility of the lower limb as well. Okay, I just give you some of the examples of the neuromuscular training program that usually being used in a football team during their trainings. Okay, moving on. So the next important component is the sporting rules and policy change. Okay, rules and policy in sport are key in regulating the sports, as we all know. But some of these rules and policies has been specifically developed and changed to reduce the risk of injuries. Example of evidence-informed policies and law change includes first, there's this body checking in ice hockey, which are disallowing body checking in all level of players in 11 and 12 years old. And then this actually lead to 50% reduction in injury risk. And even they use the same they disallow the body checking in the older age group for non-elite leagues. They actually found that there is 54% reduction in injury risk, okay, which is actually very quite prominent, okay. And the World Rugby Executive Committee has recently approved a package of law amendments to be trials to prevent injuries. One of the 6 laws to be further trials include the tackle technique warning. And this law has been successfully trialed at the World Rugby Under 20 Championship for the past 2 years, and it's actually show a reduction of the incidence of concussions by 50%. Okay, and the cricket player, like what I mentioned just now, nowadays are required to wear the British Standard Compliance helmet when battling, wicket keeping, or fielding close to the battles. However, the further research is needed on the impact of these rules and policy changes in sport to prevent sport injuries. Okay, so moving on is the use of the appropriate protective equipment may actually prevent the musculoskeletal injury in sports. Such equipments may include the helmets, the mouth guard, bracing, and also wrist guard. Dizon et al. Investigated the protective effect of ankle taping and bracing in previously injured adults and youth athletes, and he found that the risk of an ankle sprain re-injury was reduced by 69% and 69% in adults and 71% in youth athletes. However, taping or bracing is not a strategy for primary prevention, okay, in a healthy populations with no previous history of ankle injuries. And moving on to the use of the wrist guard in snowboarding show a significant protective effect in reducing the risk of wrist injury, wrist fracture, and also wrist sprain. So a combination of educational approach through either through the social media or legislations may be a good way to promote the use of this protective equipment which allow and is required. Okay, the last very important component in sport injury prevention is the appropriate surface. So playing surface that provide different shoe surface traction and shock absorption property has been linked to injury risk. In terms of natural grass, the perennial real grass is better than the Kentucky bluegrass or the Bermuda grass because the perennial real grass actually create less thatch and produce lower shoe surface tractions. Okay, how about the artificial turf? Okay, early generations of the turf were associated with increased risk of injury due to minimal padding and also high friction coefficients. Okay, however, the recent systematic review concluded that there is this little evidence of any difference in overall injury risk between the natural and the newer generations of artificial turf. Okay, now I will move to the preventions programs for certain common sport injuries, okay, including the hamstring strain, the ankle sprain, acute knee injuries, and overuse injuries. First, we look at the prevention of hamstring strain, which is very common, happens in some of the certain sports, okay. Hamstring strain is frequent in sport involving maximum sprinting and accelerations, okay. Can anyone guess what's the common sport that have high prevalence of hamstring sprain? Anyone? Okay, football. Okay, so example is like sprinting, football, basketball, rugby, dancing, and water skiing. Okay, so the injury mechanisms behind is usually occur during the maximum sprinting, okay, and usually occur at the late swing phase before, just right before the heel strike or during push off. Okay, why is it so? Why is it during this phase? This is because during this late swing phase, just right before the heel strike, the hamstring activities is the highest, okay, because the hamstrings work eccentrically or transform from eccentric to concentric muscle actions. That's why it's actually prone to actually sustain the hamstring strain. Okay, so what are the risk factors that associated with hamstring strain? There are numerous risk factors for hamstring strain. All these can be classified, as I mentioned earlier, into either intrinsic or extrinsic factor, and then subclassified into modifiable and non-modifiable risk factor. But some of the risk factor that I want to highlight are the most prominent one, being the following four intrinsic risk factor, which is age, previous history of hamstring strain, reduced hip range of motion, and also poor hamstring strength. Okay, first we talk about age. So older players are at increased risk of hamstring strain, although the older player tend to be more likely to have a previous history of a hamstring strain, but increased age itself is actually an independent risk factor for hamstring strain. Okay, so another important risk factor is the history of previous hamstring strain, which can greatly increase the injury risk and is recorded in numerous studies. Injury can cause scar tissue to form in the musculature, resulting in less compliance area with increased risk of injury. A previous injury can also lead to reduced range of motions or reduce in strength, thereby indirectly affecting the injury risk. So a footballer with a history of a previous hamstring strain have a 5 to 7 times higher risk of re-injury of the hamstring. Okay, the third important risk factor is the limited hip range of motions, especially in patients with limited hip flexions. This could mean that the muscle tension is at its maximums when the muscle is vulnerable, close to maximal length. Okay, and the fourth one is low hamstring strength. That would mean that the force necessary to resist the knee flexions and initiate the hip extension during the maximum sprain could surpass the tolerance of the muscle tendon unit. So the hamstring strength is often expressed relative to quadriceps strength, as the hamstring, if you could remember, the hamstring quadriceps ratio, which is the relationship between the ability of the quadriceps to generate speed and the capacity of the hamstring to resist the resulting force. Okay, other important risk factors include the short muscle fascicle length, especially in the long head of the bicep femoris, is also an independent risk factor, especially when combined with low level of eccentric knee flexor strength. Notably, the greater risk of future hamstring strain in older players or those with previous history of hamstring strain is reduced when they have longer fascicles and high level of eccentric strength. And then another significant risk factor will be the race. Okay, surprisingly, okay, player of Africans or Australians Aboriginal origins often sustain significant more risk of a hamstring strain than the Caucasian player. This is because this player usually they are the faster runner, and because of the higher proportions of the type 2 muscle fiber. So a faster running speed usually will generate a higher hamstring torque, which will increase the risk of hamstring strains. Okay, for an athlete that presented with hamstring strain, the causal factors are most of the times are multifactorial. Please bear in mind, and the reduction of single risk factor is usually unlikely to address the issue of the athletes, and thus it's actually crucial for the medical team, especially the sport physicians, to evaluate which factors are clinically relevant and address all of those risk factors and include in part of their rehabilitation programs. Next, I want to show you the prevention programs for hamstring strength, the standard stretching protocols.
Hey guys, here we are again. We're gonna do today a little bit of stretching. So what you need is just a space your home, a little space, and yeah, you'll be cool. I hope you enjoy. So you can do this before your training or maybe when you finish your training as well. Okay, let's do this. So guys, here my friend Shina. He's my friend. He's a personal trainer as well like me. And yeah, so he's gonna do a little bit and then I'm gonna explain you how it's gonna be, okay, the stretching. So Shina, let's start. You can open your legs. Open more if you can. Yeah, let's going down. He's really flexible. So guys, if you can't go onto the floor, it's fine, but just try. He's stretching the both legs. You can hold there for like the 30 seconds. It'll be great for you. So now, Shina, you can go to your left leg. Left one, yeah, that's good.
Sorry, I tried to erase the yellow line, but I couldn't find the eraser.
Hold for 30 seconds, and then you're gonna go for your right leg now. Great job. Yep. So now let's go a little bit from Shina, a little bit more. Yeah, that's it. But the most important, you keep hold your foot on the floor. That's really great. It's a good exercise. After that, we're gonna go back. You can go back more, Shina. Like try to take that back. Have a look how he's doing. Doing great actually. For 30 seconds. After this one, you can close your leg, Shina, a little bit, really slow. Close. Now you're gonna work your hamstring really well. That's good. After that, he's gonna go up, and then after this one, you bend one knee and then you stretch another one, Shina, and take your leg with your two hands. That's perfect. Yeah, that's really good. He's stretching his calf, his hamstring as well. You can change your leg. That's great. Well done. Good job. The next one is really good for your hamstring. So Shina, let's go in front to work your hamstring now. Stretch both legs. Yeah. You can see that both legs are stretching. You try your best, yeah? I know everyone is different, but let's try to do like he's doing right now. Looks great. That's it. You can change your leg, Shina. Yeah. Excellent exercise. Good job. That's it, Shina. Let's look. Stand up and hold one leg. Yeah, concentrate, like get your balance. So you need to look to somewhere and fix that. You can see he's stretching really well for 30 seconds. Then after this one, you're gonna work your hips. So let's go to your hip straight, Shina. Yeah, that's good. Make sure you open your chest. You can open your arms like that. So It's going to be great for you. That's really nice. Let's change again, Sheena, to another leg. We are nearly done, guys. After this stretching, you're going to be ready to start the workout. Change again, Sheena. Let's go to your hips. Open your chest. Open your chest. Yeah, that's great. Well done. Good job. That's it. Great job, Sheena. Thanks a lot, guys. I hope you enjoy. Hey, guys. Here.
Okay. Can you actually see the yellow line?
Hello, sir.
Yeah. Can you?
What you can do is you can re-share your screen, sir, so that the yellow line will be eliminated.
Yeah, I'm really sorry for that. Okay, is it better? Is the yellow line still?
Yes, sir.
Yes, sir. Yes, sir.
Okay, I'm really sorry for the yellow line. I didn't purposely draw it. Okay, just now what you have see is the video showing stretchings of the hamstring muscles, but as you can see, the player is just not focusing on stretching hamstring alone. It's actually involves stretching of the whole lower limb, including the quads, the glutes, and also the calf muscles. So this is important to incorporate the whole lower limb stretchings whenever you are developing the hamstring injury prevention programs. Okay, another very famous hamstring prevention programs is this what we call the Nordic hamstring exercise, or the another name is Nordic lower exercise. So Nordic hamstring exercise is easy to implement in a team settings. However, to avoid the delay onset of the muscle soreness, which is that is the very common complaints by most of the athletes that actually practice this exercise. So it's important we ask the athletes to follow the recommended exercise prescriptions as shown in this table here. Okay, and gradually increase the training load when introducing this exercise programs. Okay, so by in the end of the 10 weeks training periods, most of the players are able to stop the downward motion completely before touching the ground, which is about 30 degrees of the knee flexions, even after being pushed by their partners at considerable speeds. So when a player can reach this stage, the characteristic of the Nordic hamstring lower exercise appear to resemble the typical injury situations, which is the eccentric hamstring muscle actions with high force and near full extension. Okay, so this is what this exercise want to achieve, actually to resemble the injury situations. Okay, and this program has been implemented in several different sports in younger age group, and injury from exercise itself has so far has not been recorded if done gradually. Okay, I have a video to show about apart from the Nordic hamstring lower exercise, there is some other alternative of best hamstring strength exercise that you can actually use to strengthen the hamstring muscles.
In this video, we will look at the 4 best exercises for hamstring training in elite sports. Lots of research is done on hamstring injury prevention and rehab.
It appears as if the Nordic hamstring curl is the holy grail of hamstring exercises, but we wondered if there is more to regional muscle use during hamstring strengthening, especially considering that there are 4 muscle bellies, the semimembranoses and semitendinoses, as well as a long and short head of the biceps femoris. Research by Mendes Villanueva et al. From 2016 examined which hamstring exercises result in the best site-specific muscle use. What they found is that the flywheel curl and, to a lesser extent, the Nordic hamstring curl target the short head of the biceps femoris, whereas the hip extension conic pulley promoted the selective use of proximal regions of the long head of the biceps femoris while minimizing activity in the other muscles. So for general hamstring strengthening or focus on biceps femoris short head and semitendinosus and membranosus, the flywheel leg curl and Nordic hamstring curl are excellent exercises, with the Russian belt exercise as an add-on. For more specific targeting of the proximal biceps femoris long head, you may want to opt for the hip extension conic pulley. So let's look at the 4 exercises. Start in a kneeling position, keeping the torso from the knees upward in a rigid and straight position. Ask a buddy to apply pressure to the heels to ensure that the feet stay in contact with the ground throughout the exercise. Then resist forward falling for as long as possible, focusing on the eccentric contraction of the hamstrings. Buffer the fall with your hands, let the chest touch the ground, and return to the starting position by pushing yourself up. As our filming facility is not equipped with a flywheel leg curl machine, we will use a different prone lying setup. Lying on a bench with one leg attached to the cable pulley, form knee flexion in a concentric manner and return to the starting position with a controlled eccentric movement. Stand on a slightly inclined surface of about a 45-degree angle. The belt or strap is placed just above the knees. With the pelvis in anteversion, lean forward through engaging hip flexion, focusing on the eccentric contraction, and try to touch the floor with the hands. Return to the starting position by concentrically engaging hip extension. As there is no gravity-independent pulley device available at our filming facility, we will use a standard cable pulley. To do this exercise, attach a strap above the ankle, which is then connected to the cable pulley. Lie in supine position with the legs facing away from the machine. Ask a buddy to block the free leg to prevent it from rising. The concentric phase of this exercise, so hip extension and slight knee extension, is done during the descending phase, and eccentric hip extension while the leg is lifted back up. Make sure to also emphasize core activation during the exercise. In this video, we will look.
Okay, as you can see, beside the except the Nordic hamstring exercise, which actually you need partner to help you. The other 3 exercises that demonstrated in the video just now can actually do alone, pretty simple with the gym equipments. Okay, so there's these articles published in the BJSM by the Matthew Batrops. So Matthew Batrops actually mentioned that there's this last disconnections between the research evidence and the real-world adoptions of the Nordic hamstrings exercise in elite footballer. Okay, so in this paper, he mentioned that although Nordic hamstring exercise program has been shown to be effectively reduce hamstring strain by up to 65 to 70%, which is very high. A recent survey of the elite European Champion League and also the Norwegian Premier League team show that only 11% of this team fully adopt the programs. Okay, and one of the main reasons is because they think the player just simply don't favor the delay onset that actually experience after doing the programs. Okay, so what Matthew suggests is like many other teams, they actually value the role of eccentric strength hamstring training, but they do not adopt the full Nordic hamstring exercise programs. Instead, they use a more holistic approach to the hamstring muscle strengthenings. We recognize the need of optimal hamstring functions, which is the maximal and explosive strength across the force velocity profile, and also the balancing and also the focus, balancing the focus on isometric and eccentric and concentric actions. Okay, what are the strategic that that actually proposed by the Matthew is that in order to prevent the hamstring strength in elite footballer is the first one is to strengthen the hamstring muscles. The second one is to optimize the training loads by carefully monitor the player and then to ensure the optimal recovery strategy. The third one is to implement beside the hamstring also to focus on a lumbar pelvic hip stability. And the fourth one to develop the player physical conditionings. And the fifth one to incorporate a focus on movement qualities. Okay, I just stop and share first. So stop sharing because the red line appear again. Okay.
We are requesting the participants, please do not put any marks on the presentation of the speakers. Thank you.
Oh, okay. It's the participant putting the marks lah. I thought I accidentally put the marks. Okay. Okay. No problems. Okay. Now we move on to preventions of ankle sprain, which is also very commonly happen. So estimated about 25% of all sport injuries are ankle injuries. So highest rate of ankle injury happen in sport that characterized by running, cutting, and jumping. Example like basketball, football, and also volleyballs. So the mechanism behind usually involve the landing or stepping with the positions of the foot in inverted, which is plantar flex, inverted, internal rotated, and supinated. Okay, why is it so that in these positions the foot, the ankle is prone to get injuries? This is because the bony stability of the ankle mortise is reduced when the foot is plantar flex, as the posterior talar platoon is more narrow than the anterior portions. Okay, the posterior talar platform is more narrow than the anterior portions. Unless the dynamic muscular tendinous ankle stabilizer can compensate for the reduce in bony structure stability when the ankle joint is perturbated, the ligament that statically stabilize the lateral ankle are acutely overloaded when the athletes load weight on the inverted foot. Okay, that's why in footballer, such perturbations often occur from tackles where the player receives either a lateral directed hit on the medial side of the ankle and land in a supinated position that lead to an inversion ankle sprain. And in other sports like volleyball and basketball, the injury often result from landing on a foot of the opponents or teammates. So what are the risk factors that are associated with ankle sprains? The most important risk factors that has been identified for ankle sprain is history of previous ankle sprain, just like history of previous hamstring strain. Okay, so especially there is a previous history of ankle injury for the past 12 to 24 months. In fact, study has shown that 4 out of 5 ankle sprain occur in a previously injured ankle among the adult athletes. So the risk of re-injured is actually fourfold greater for an ankle that has been sprained one or more time. Okay, the more recent the injury, and that is the higher the risk of re-injury. Following an ankle sprain, the proprioception of the ankle is affected, hampering the stability that subsequently lead to a more inverted position upon landing from a jump or strike, as well as lesser control over the dynamic muscular tendinous ankle stabilizer to counteract the perturbations. Then this lead to the higher chance of re-injuries. Okay. Another important risk factor is the postural stability of or the postural sway. So the postural sway is closely related to a previous ankle sprain occurrence and can be assessed by measuring the durations of the athletes to maintain a single leg stance without touching down to recover balance. So athletes who are able to maintain a single leg stance for at least 15 seconds are considered to have a normal posture. So you can actually practice yourself. If you cannot maintain a single leg stance for 15 seconds, that means you are probably having an abnormal posture. So athletes with abnormal posture are more likely to suffer from ankle sprains. Okay, moving on. So what are the preventive measures that we can use for ankle sprains? Okay, there is this strong evidence for two recommendations. The first one is the tapping or bracings that should be recommended for a period of up to 12 months after an ankle sprain when the risk of injury is increased several times. The mechanism of which the tapping or bracing work is still actually until now not unclear, but they actually postulated that this might actually enhance the athlete proprioceptions of the ankle joints. So you can see here, this is the rigid tape, and that the initial tape, and that is actually the ankle brace. Okay, so ankle taping actually restrict the inversion motions, although it appears that the ankle support are more superior than the ankle taping because the ankle support do not lose their ability to restrict inversion or tapping. Over a period of time, they will loosen up after several cycle of jumping, running. Okay. Another important preventive measure is actually through the neuromuscular or sensory motor control. Okay, so training of the neuromuscular part, which include the proprioception or sensory motor and balance exercise of the affected ankle joint, which will have shown that can restore and will help in preventing from the ankle from re-injuries. Okay, a balanced board program has also been shown to reduce the risk of re-injury in functionally unstable ankle in footballer and appear reasonably to recommend a program of 10 to 20 minutes of balance boards, or we can use, we also call Wober boards, the Wober boards balance training 5 times per week, and then 10 to 20 minutes for every time, and then to continue for 10 to 12 weeks for all athletes with history of ankle sprains. Okay, I just want to show you that we know that the tapping, bracing, and neuromuscular training are all effective preventive measure for ankle sprain. But do you know which one is the best preventive measure for ankle sprain? Make a guess. Is it the taping, the bracing, or the neuromuscular training? Okay, don't know, not sure. Okay, so the answer actually depends on the preference of the athletes. Okay, because the preventive measure that the athletes prefer is the most likely to be adopted by the athletes and achieve the best results. However, a combinations of extrinsic prophylactic measure, which is the tip of the brace, with the neuromuscular training, will probably achieve the best preventive outcome. As you can see in the graph here, there is occurrence of ankle sprain, and then this is right after the ankle sprain occur, and then after 8 weeks, after 12 months. Okay, so there is this ankle sprain re-injury risk. So when you are only using no protective measure at all, so you will actually have the athlete actually sustain the higher risk. So if the athletes only do the neuromuscular training, okay, the risk will be reduced by almost half. And if there is combinations of neuromuscular training with the external measure, then the risk will even reduce further to probably zero. Okay. So the extrinsic measure will provide. Why is it important to actually combine these two? Because the extrinsic measure provide the immediate protection, but only when the athlete wear it, as they only provide support for a previously injured ankle, and they do not target the underlying neuromuscular impairment that the athletes already have. So the neuromuscular training, in the other hand, will target the underlying risk increasing pathology. But the training itself will take some time to take effect before a preventive effect is established. So when the extrinsic measure, which is the tip of the brace, where during the period of neuromuscular training, the patient will benefit from both, from an immediate risk reduction effect while targeting the underlying cause of the increased risk, increased recurrent risk of ankle injuries. Okay, so now we move to prevention of ankle acute knee injuries. So I will just focus on ACL rupture because this is the one of the most common types of and most usually quite serious in sport injuries. And ACL rupture can result in high treatment costs, long rehabilitation time, and there is also increased risk of develop post-injury osteoarthritis at later stage. Okay, so the injury mechanism usually most of the time is the non-contact injuries, and then and can also occur during cutting maneuver or a single leg landing after jumping. Okay, so the cutting maneuver are usually associated with a dramatic increase in the varus and valgus, and also internal rotation as well as decelerations. So this is a very good diagram showing the mechanism of ACL injuries. Okay, so the typical non-contact ACL injuries occur when the knee is externally rotated, and in 10 to 30% of flexions, when the knee is placed in a valgus position, while in the knee is valgus positions, about 10 to 30 degrees of flexions, as the athlete is taken off from the foot is planted, and the athletes tend to rotate the body to the opposite side with sudden changes of direction. So this position is what we call the point of no returns. Okay. Okay, so there are also a lot of risk factor for ACL injuries. So the most important risk factors is the female gender. We study in football, basketball, and handball, showing that female have about 2 to 5 increased risk of ACL injury. The reason for this is actually not completely clear, but the postulated factors are different due to difference in landing biomechanics, the neuromuscular control, in which female actually land with the knee more extended and valgus positions because of the hip is internally rotated, and female tend to have a smaller femoral notch, smaller ACL size, and then female also have hormonal changes, and ACL is at greater risk of injury, especially during the first half of the menstrual cycle, which is the pre-ovulatory phase. And another factor is female also tend to have a lower limb alignment, and there is this genetic predispositions, which is the underrepresentations of the CC genotype of a CO5A1 genes, CO5A1 gene sequence in female with ACL ruptures. Okay, recent study also showed that a history of previous knee ligaments injury is the predominant risk factor. Like all the other injury, history of previous knee injury is also an important risk factor for a subsequent injury. Example, rupture of ACL graft, um, and an ACL rupture of the contralateral knee, or even might actually end up with another serious knee injuries. Okay. For the extrinsic risk factor of ACL injury in handball and Australian football is the high frictions between the footwear and player surface that cause the foot to stop abruptly during a cutting or a turning maneuver, and thus increasing the stress on the knee. Okay, so the preventive program for acute knee injury should actually include a structured exercise program targeting the strength, balance, neuromuscular control, and reduce the rate of acute knee injury by about 25 to 50%, and usually should perform as a structure warm-up prior to the trainings. The aim is to alter the quality of the lower limbs movement, increase the core stability, increase the awareness of the knee position in relation to the foot, and emphasize on the alignments of the hip, knee, ankle, and foot. Okay, so recent systematic review recommended that the best efforts, the preventive program should be aimed at younger athletes, perform more than 20 minutes durations at a minimum of 2 times per week, and include exercise variations and also verbal feedback. Okay, one of the very common injury preventions programs is the FIFA 11 Plus. I'm sure everyone is quite familiar with that, which was developed by FIFA International Group of Experts. Is actually a good example of a multi-faceted 20 minutes warm-up programs that actually include not just the lower limb strengthening exercise, but also include the core stability, the balance, the strength, and also the running exercise. So youth football team using the FIFA 11 Plus as a standard warm-up had a significant lower risk of injury than the team who do not warm up using the FIFA 11 Plus. And team that perform the FIFA 11 Plus at least twice per week has 37% fewer training injury and 29% fewer match injuries. And actually the FIFA 11 Plus can be divided into 3 parts. Okay, the first part will be the running exercise at low speed, which combined with active stretching and control partner contact. And the part 2 consists of 6 sets of exercise focusing on the core and also the leg strength, balance, and plyometric agility, and each with 3 levels of increasing difficulty. And the part 3 consists of the running exercise at moderate and high speed combined with planting and cutting maneuvers. So FIFA 11 Plus is an effective injury prevention warm-up program that was developed for football players. However, the similar warm-up programs also exist for other sports such as floorball, handball, and they actually adopt the same concept to be applied into other sport like the FIFA 11 Plus programs. Okay, we move to the last part of the injury preventions, which is the overuse, preventions of overuse injury. As we know, overuse injury often occur among athletes, regardless of all level or age, but in particularly in elites athletes and also young athletes, dedicated athletes who total training and competition load increase rapidly. Okay, so the inciting event for overuse injury, if you still remember the injury causations models, okay, the inciting events is actually cumulative tissue overload that occur over time. And then there is this close monitoring of athletes training and competition loads may be effective preventive strategy. The secondary prevention of overuse injury include early identifications and rapid initiations of appropriate treatment plans. Okay, so preventions of overuse injury include the stretching, structure training programs, technique modification, nutritional strategy to prevent a stress fracture and modify the extrinsic risk factor like the footwear. So later I will further explain about the barefoot and minimalist running, whether there is any evidence. Okay, and then the orthotic insole and sport equipments. Okay, so stretching, we can actually do a targeted stretching over the glenohumeral joint. If you are having some tendinopathy of the rotator cuff tendons, then the targeted stretchings of the glenohumeral joint should involve internal rotations to reduce the risk of overuse injury, especially in throwing and overhead athletes and also in handball athletes. Example are tower stress, the cross arm stress, and also the overhead shoulder stress. Okay, so the structured training programs, like what I have explained just now, should be multimodal, multifaceted training targeting muscle strength and also neuromuscular control. Example like FIFA 11 Plus can also be used for to prevent the overuse injuries. However, this promising result, which has not been consistently replicated in adult populations, particularly in amateur athletes, elite athletes, and military recruits. Okay, so although FIFA 11 Plus is very famous, but they has not been able to replicate the same results in some of the study. They mentioned, especially in elite athletes and also in military recruits. Okay, another important component in preventive measures for overuse injuries is actually to modify the wrong techniques. So always important to ensure optimal sporting technique, especially in sport involving the repetitive loading patterns. Okay, like in runners, okay, it's important to have a neutral hip when running. So when there is this heel drop occur, okay, that will actually cause excessive contralateral hip drop, which we also call the Trender-Lambert gaits. This can actually cause in long term the lower limb and also lower back injuries. And then another example in techniques will be the tennis player is actually advised to use a double-handed backhand rather than using a single-handed backhand shoot to prevent the tennis elbow. So moving on to nutrition. Okay, so we know that calcium and vitamin D is very important for our bone mineral density. So when there is lack of those nutritions, then there is increased risk of stress fracture. So different countries have their different own nutritional recommendations. Usually the calcium intake will recommend at 1,000 to 1,200 milligram calcium per day. Vitamin D will be about 600 to 800 international unit per day. However, the requirement, like what I say, may vary for different individual according to many factors. Some of the factors that will influence the vitamin D intake will be example like sun exposure, people with dark skin, medical conditions that interfere with fat absorptions, example like Crohn's disease. Okay, and then now we move to footwear or the barefoot or minimalist running. Okay, recent randomized control trials show that there's no evidence in individual prescription of different footwear, regardless of whether it's cushioning, motion control, or stability footwear, based on the static foot alignment in reducing the overuse injury. There's no evidence. Okay, and there's also no evidence of the using the barefoot or minimalist footwear running is effective in preventing the overuse injuries. Okay, how about the orthotic insoles? Yes, there is several high quality meta-analysis that actually supported the use of orthotic insoles. Can be either fabricated or custom made. And this actually has shown a significant preventive effect for a range of lower limb overuse condition, such as stress fracture, medial tibial stress fracture, which is the spectrum of stress injuries, and then the patella femoral pain and Achilles tendinopathy. And the last one is the use of the sport equipment. It's important to carefully select the appropriate sport equipment, because this will actually play a very important role in the prevention of overuse injuries. Okay, I finished my first part of the my talks. Now I will be continue with the sport rehabilitations. Is that all right?
Yes, sir.
Okay. I know I already exceeded 20 minutes, but I'm gonna go pretty fast for this. Okay, for sport rehabilitations, okay, in Latin, the rehab actually come from the Latin words mean again, and habitates means make fit. So in combination is we make fit again. Okay, so it's actually defined as restorations of optimal form of anatomically and also function through physiologically. And the process is targeted to minimize the loss associated with acute or chronic injury and to promote recovery to maximize the functional capacity, fitness, and performance. Okay, so tissue injury can actually classify into two main types, which is the macro trauma, which is due to the strong force. Example from the fall, accident, collisions. Okay, and more common occur in contact and collision sport such as football, rugby. Okay, and this injury can be primary by direct tissue damage or secondary due to transmission of the force or release of inflammatory mediator to the from the injured side to the other side. Okay, so on the other hand, the microtrauma injuries refer to the chronic injuries that result from overuse or repetitive stress injury of a structure, such as usually the muscle, joint, ligament, tendons. And this type of injury is more common in sport that require repetitive movement, such as swimming, cycling, rowing. Okay, Musculoskeletal injury are an inevitable result of sport participations. We cannot run away. When we participate in sport, there is actually risk of injuries. So recreational and competitive athletes usually account for a significant number of musculoskeletal injuries. Among all the sport, probably because football is usually the sport which is have well studied. So football has the highest incidence of catastrophic injury, and then followed by gymnastics and ice hockey. And the rehabilitation process should start as early as possible after an injury and form a continuum with the other therapeutic interventions. The rehab can also start before the before or immediately before the surgery, which is called the prehabilitations, or immediately after the surgery when the injury requires a surgical intervention. Example is like ACL reconstructions for ACL ruptures. Okay, so the goal of the rehab program is usually to limit the extent of the injury, to reduce or reverse the impairment or the functional loss, to prevent or correct or eliminate altogether the disability, and to restore to the activity of daily living, and last but not least, to return to the first is the participations level, and then to return to sport, and then to return to performance. Okay, so regarding this return to sport, is actually reviewed as a continuum, okay, throughout the rehabilitation process and along the performance spectrum. So according to the 2016 consensus statement on return to sport from the first World Congress of Sport Physical Therapy, they actually mentioned this continuum of return to sport as having 3 stages, like what I mentioned just now. So in return to participation phase, the athletes may be able to participate in modified or full training session with decreased time or with different role in a game, match, or competition, but they are not yet playing at their goal level of play. Okay, this could be a number of reasons, including the tissue is not completely healed yet, or they are not physically fit, the mental is not ready yet, or other contextual factor that keep themselves from fully return to sport. Okay, so the second continuum is from the return to participation, then they will move to return to sport. In this phase, athlete is now fully participate in their own sport, but it's not at their desired performance level. This can occasionally be the point at which the athletes has decided they have successfully completed return to sport. Okay, what is meant by this? Like for example, for university football player, okay, which actually tear his ACL at the last semester, okay, so and he has no expectation of playing professional level after graduate, okay, so he might actually just satisfied with just return to sport, although he doesn't achieve the pre-injury level of performance. Okay, so but in the other hand, if you are talking to a professional elite footballer, okay, who is in the first year of his contract, okay, this may be the point in which he has returned to playing without limitation, but he is not able to achieve the performance goal and are coming off the bench instead of being a member of the starting line out. So for this kind of player, if he just able to achieve the return to sport but not return to performance, this is actually not adequate. Okay, and the last level is the return to performance, is when the athletes has met and even exceeded the level of performance they were achieved during at the pre-injury stage. So the athletes is working towards higher performance goal, achieving personal records, and has improved metrics of performance to a better level than the prior to the injuries. I want to introduce this very nice blue umbrella. Okay, it's called the umbrella or sport rehabilitation. So this umbrella actually consists of is actually made for the athletes and actually consists of a multidisciplinary team with usually the sport physicians or a doctor or sport doctor that are functioning as the leader and coordinator of the athletes' care. And the team will actually manage, there's actually two teams under this umbrella. One is the injury care and management team, and the other one is the performance enhancement team. So under the injury care and management team, there is actually many members. There is sport physicians, which usually the leader, and then there is other specialists from other specialty like sport orthopedic surgeons, neurosurgeons, radiologists. Depends on the type of the injury the athlete is sustaining, and then sometimes if it's involved oral injury or if it involves a mouth guard, denture, then the sport dentistry will actually required. And then there's also physiotherapists or physical therapists, alliance health professional like nurse, assistant medical officer, athletic trainer in some of the country, and sport podiatrists, the chiropractor, and also orthodontics and orthodontics. Okay, so in other hand, the performance enhancement team actually is also important. Okay, that actually include the coach, okay, the exercise physiologist, the sport biomechanics, the sport psychologist, nutritionist, strength and conditioning specialist, and sport massage therapist. So this rehabilitation team is important to work closely with the athletes and also the coach to establish the rehabilitation goal and to discuss the progressions from the various targeted individual interventions, and actually to establish the time frame to return for the athletes to return to training and competition, and also last but not least to the performance at the pre-injury stage. Okay, so communication between the team member is vital. Okay, and lack of communication or breakdown of communications can actually slow and prevent the athletes from returning to the peak capacity and increase the risk of getting a new injury, or even worse, having a devastating re-injuries. Okay, I think we actually have mentioned the 7 principles of sport rehabilitation. So I just want to quickly go through. Anyone know what is this testing battery? This is actually the star excursion balancing test. Okay, so the mnemonics of the principles of the sport rehabilitation is actually ATC, is it? Okay, so A stand for avoid aggravation, which is important not to aggravate the injury during the rehabilitation process. So or therapeutic exercise, although it's important, but if you administered wrongly, sometimes can further exacerbate the injuries. Okay, and T stand for timing. So in rehabilitations, the timing play a very important factor. The sooner the athletes can begin the rehabilitations, the sooner he or she can return to the full activity. So following injury, sometimes rest is necessary, but too much rest can actually result in detrimental to recovery. So athletes can, however, rest the body part that is not injured and work the rest of the, athletes can rest the body part which is injured, but work the rest of the body. Okay, this is usually we call relative rest. Example, like the athlete sustained ACL ruptured, but he still can train on his core and also the upper limb training. There's no issue on that. Compliance is C actually meant for compliance. So compliance is important because without the compliance, the rehabilitation program will not be success. And to ensure compliance, it's important to inform the athletes about the content of the program and then the expectation of the rehabilitations. Okay, and setting goals, including athletes in decision making, work as a motivation factor to continue the rehabilitation process. Thus, goal work as a motivation factor, increase the efforts to reach the goal, and thereby increase focus, endurance, and direction for the athletes to continue and compliance to the rehab programs. I mean individualizations. So each person respond differently to different kind of injuries, and also even to the rehabilitation program. So we have to individualize the rehab program, and probably to form a targeted individual rehab program based on the injury that the athlete sustains. So even though an injury may seem the same in type and severity as another, undetectable difference can change an individual response to the rehab program. So individual physiology and psychological difference profoundly usually affect an athlete's specific response to injuries. S actually stand for the specific sequencing. So rehab program should follow a specific sequence of event. So this specific sequence is determined by the athlete respond physiologically to the healing process. So we always, when we are doing the rehab program, we have to monitor the athlete's progressions and also the recovery. I actually stand for intensity. The intensity level of the therapeutic exercise must challenge the athletes and the injured area, but at the same time must not cause any aggravations. Knowing when to increase intensity without overtaxing the injury require observation of the athlete response and considerations of the healing process. Okay. T stand for total patient. Total patient mean we are approaching the athlete as we are treating the athletes as a whole with holistic approach. So this is actually important for the unaffected area of the body to stay finely tuned. This actually mean like even though the athletes already sustain injury, because we want to maintain we have to maintain the athletes so that the fitness level won't drop. So it's important to keep the cardiovascular fitness at the pre-injury level and maintain the range of motion, strength, conditioning, muscle endurance of the uninjured limb or even uninjured joint. So the whole body must be the focus of the rehabilitation program, including the psychological aspect, not just the physiological body part. Okay, so so this is important to provide the athletes with a program that will keep the uninjured area in peak conditions, and at the same time treating the injured area, because this will actually help the athletes to better prepare physiologically and psychologically for return to play when the injured area is completely recovered. Okay, so the fundamental components of rehabilitation program include the pain management, the range of flexibility, the strength and endurance, perception and conditioning, functional training, orthotic, psychological of injury. I will go very fast on this. Okay, so the first one is the medications. Medication are the mainstay of treatment in the injured athletes, both for their pain relief and healing properties. It's recommended that we have to use medications judiciously with distinct regards for the risk. Always risk always have to weigh the risk over the benefits before prescribing any medications. Okay, usually the medication that we use includes analgesia or muscle relaxants at the early stage for pain relief or at the early stage of rehabilitations, because sometimes too much pain, they can't even do any therapeutic exercise. So electrotherapeutic modalities also play a small but important part in the rehabilitations. They may help to reduce pain and edema and allow the exercise-based rehab program to proceed. Okay, so by understanding the physiological basis of different modality, a safe and appropriate treatment choice can be made, and the effectiveness will ultimately depends upon the athlete individualized and also subjective response to the different type of modalities. And then we move to the sport massage therapy. Sometimes may help to relieve pain, control swelling, and enhance performance. But please don't massage when there is a acute injuries or when there is acute swelling. Okay, so the manual therapy usually involve manipulation of soft tissue that designed to assist in correcting the underlying problems or imbalance in soft tissue, and that these underlying soft tissue injuries are usually caused by repetitive and strenuous physical activity or trauma. Okay, some of the other complementary therapy like dry needling, acupuncture, cupping, sometimes also used in musculoskeletal pain management, but the evidence is not is actually sparse. Okay, moving on to the range, ROM, and also flexibility. Injury or surgery can result in reduced in range of motions, mainly due to fibrosis or wound contractions. The most common, beside that, it's also common to have a post-injury flexibility reductions as a result of muscle spasm, inflammation, swelling, and pain. In addition to impacting the injured area, this reduced in range of motions can also affect the joint above and below of the injured site and create motor pattern issues. Okay, so flexibility training is important as part of the rehabilitations in order to minimize the reduction in the joint range of motions. A variety of stretching technique, example like in the picture, is actually the proprioceptive neuromuscular facilitations, ballistic stretching, static stretching might also help in improving the range of motions. Okay, moving on to strength and endurance. Injury to the musculoskeletal system could result in skeletal muscle wasting and weakness, loss of aerobic capacity, and fatigability. So during the rehab process, after the sport injury, it's important to maintain the cardiovascular fitness. Example of exercise that can improve the cardiorespiratory endurance include if, let's say, the athlete sustain ACL ruptured, then he can actually do arm cycles. If there is a overhead athlete sustain shoulder injury, then they can actually do regular by cycling or even one leg cycling. Sometimes for patients with osteoarthritis or knee injuries, they can go for pull exercise like hydrotherapies or general major muscle exercise program with relatively high intensity and short interval like the HIIT, circuit weight training can also be useful in training the strength and also the muscular endurance. Okay, we move to the proprioceptions, which is defined as the sense of joint or limb positionings. So loss of proprioceptions occur in with injury to the ligaments, tendons or joints, and also with immobilizations. Proprioceptions re-education is important to engage back the muscular receptor working in order to provide a rapid motor response. So restoration of these proprioceptions is an important part of rehabilitations, and the treatment have to be adapted to each individual, to each athletes, considering the type of injury, the stress to which the athletes will be exposed when practicing his or her own sports. Coordinations actually defined as the capacity to perform movement in a smooth and precise control manner. Improving the coordinations depends on repeating the positions and movement associated with different sport and correct training. This has to be gained with a simple activity, perform slowly, and then perfectly execute, and then gradually increase in speed and complexity. So the physiotherapist should make sure the athletes perform the movement unconsciously until they finally become automatic, or what we call the spinal reflexes. Okay. Okay, moving on to functional trainings is actually important as part of the rehabilitation programs, and because we have to take into account to actually design a programs that can reproduce the activity and movement that required when the athlete return to the field after the injury. So this is where the functional or the sport specific training come in. So the goal of the functional-based rehabilitation program is actually to return the athletes to optimal athletes functions, which is the result of physiological motor activities, creating specific biomechanical motions and positions using the intact anatomical structure to generate force and actions. Okay, now the use of orthotic device is also important to support the musculoskeletal function and to correct the muscle imbalance and inflexibility in injured and uninjured area. Appropriate orthotic applications will result in restrained force that will oppose the undesired motions. A complex orthotic prescription should take into considerations of patient diagnosis and the type of the footwear the patient use, and also as well as the material that we'll use to fabricate the orthotic device. So if you have an orthotist, it's important to communicate with the orthotist in that will fabricate and fit the brace, and so that we want to obtain a good clinical outcome from prescribing the orthotics. Okay, last but not least is the psychological aspect of injury. Bear in mind that a sport injury is just not involving the physical aspect. The athletes also psychologically affected when he or she sustained a sport injury. So we know that sport injury do sometimes threaten the athlete's career and success, and sometimes even worse can actually end an athlete's career and have various consequences on athlete's quality of life. So the most important, the most immediate emotional response at the point of injury is shock, and the degree may actually range from minor to very significant, depending upon the severity of the injuries. So it's it's very important to take notes that denial itself is an adaptive response by the athletes that allow an individual to manage extreme emotional response to stress. So when an athlete is injured, okay, like what I say, it does not actually affect his physical capacity exclusively, but also the contextual and psychological aspect. In fact, in a given situation, injury can deprive the athletes of their compensations of increasing life stress, and also determine fear of re-injury, sensation of loss. They start to have negative emotions and other mood disturbances. So what we can do here is mental skill is actually important and often viewed as part of the individual personality, and sometimes that cannot be taught. Okay, many of the sport physicians feel that injured athletes either have or do not have the mental toughness to progress through the rehabilitation. So it's important to actually to actually ask the helps from the sport psychologist to introduce the athletes to this mental skill so that they can learn and they can cope through the psychological aspect during the sport injury. One example for this is to provide a proper goal settings, which has a very important role in sport rehabilitations, because this can actually enhance the recovery from injury. So goal settings need to be measurable and stated in behavioral terms. So there's research that indicates that goal setting should be challenging and difficult, but is achievable. Okay, so it's important for the physicians to help them to focus on short-term goals as a mean to attain a long-term goals. For example, we can actually help the athlete to set daily or weekly goals in the rehabilitation process, which will end up in the long-term goals like returning to sport after the injuries. Okay, now I move to the last part of the rehabilitations. There is actually these 5 phases of sport rehabilitations. The first one is the acute phase. The second is the restoration and the recovery phase, and then followed by sport-specific and functional phase. And the 4th phase is return to sport, and the 5th is the re-injury prevention phase. Okay, so there's these different books, different journals, they always give different terms and different phase of rehabilitations. But what I've been sharing now is actually is the one that I think is can be most appropriate and can be adopted to any kind of injuries. Okay, so I will go into detail the each of the phase. We start with phase 1, the immediate, or sometimes we call initial, acute, or inflammatory phase. Okay, so this is the first phase of the injury, which begin immediately after the injury and last approximately 4 to 6 days. And the body will first respond to the injury with inflammations. And the main function is to defend the bodies against harmful substance, dispose the dying tissue, and to promote renewal of the normal tissue. So the goal of this initial phase is actually include the limitation of the tissue damage by protecting the injured area. We try to relieve the pain of the athletes. We control the inflammation and control the swelling, and also educate the patients. Okay, so the primary treatment of this acute phase, the primary treatment usually for this acute phase, as we know, is last time used to employ the term ICE, the acronym ICE, which stand for the ice compression and elevations. Then they evolve into RISE. They add on rest. Rest in the context of relative rest. That means you rest the injured area, but other area which is not affected, you still need to train. Okay. And then over the years, they evolve into price. They add in P, which is a protection of the injured area, either by putting bandage or put a cast if there is a fracture, okay, or using a brace. And then they evolve into the police, okay. So police is stand for protection, optimal loading, ice compression, and elevations. Okay, so this police principle actually promote and guide safe and effective loading in acute soft tissue injury management. So protect emphasized the importance of avoiding further tissue damage, but didn't interfere uh, but doesn't infer with doesn't infer indefinite immobilizations. Okay, example, we will ask the athletes to use the crutches to protect an injured lower limb while the activity engaging in daily tasks. Protect could also represent the appropriate amount of rest to heal the injury as well. Okay, and then O and L actually stand for optimal loading. This will actually stimulate the healing process. As we know, bone, tendon, ligament, muscles all require some amount of loading to stimulate healing. Okay, so optimal loading is done by utilizing mechanotherapy interventions and include a wide range of manual therapy that currently available. Okay, and then the right amount of activity can actually help to manage edema, swelling. For example, in an ankle sprain, the contraction of the calf muscle help to move or pump the swelling up to the body, to the heart against the gravity. Okay, so complete rest would prevent this from happening. So in some instances, loading may be not necessary. Example, if the athlete sustain a severe fracture that requires surgery, then it's supposed to be completely immobilized. Okay. So after the police, then we move. Then latest we move to peace and love. So what does peace and love stand for? Okay. So peace and love is actually the latest principles that are employed for soft tissue injury management that include the principle of price and police. Okay, but there is so much more complexity to the management and rehabilitation of soft tissue injury. So this well-known method, the peace and love, actually focus on acute management of soft tissue injury and also address the subacute and chronic stage of soft tissue healing. So the peace and love acronyms actually include the full range of soft tissue injury management, from immediate care to subsequent management. So this acronym actually highlight the importance of patient educations and address the psychological aspect involved that will help in recovery. This acronym also highlight the potential harmful effect of using anti-inflammatory medications for recovery. So not all soft tissue or not all sport injury you have to give painkiller unless the patient's pain is intolerable and cannot even proceed with the therapeutic exercise, then you have to give. Otherwise, there is this paper research that actually say that the anti-inflammatory medications may actually affect the recovery of the patients. So immediately after a soft tissue injury, do not harm and let the peace guide you. This is what they mentioned. Okay, so P actually stands for protection. Protection means unload or restrict the movement for 1 to 3 days to reduce the bleeding, swelling, prevent the distension of injured fiber, or reduce the risk of aggravating injury, and then minimize rest as prolonged rest can actually compromise the tissue strength and quality, and then let the pain guide the removal of protection and also gradual reloading. E is elevations. Elevate the injured limb higher than the heart to promote the interstitial fluid flow back to the flowing out from the injured area to the heart. A is avoid anti-inflammatory modalities because anti-inflammatory medications may negatively affect long-term tissue healing, as optimal soft tissue regeneration is supported by various phases of inflammatory process. So making use of medications to inhibit the inflammatory process could actually impact the healing process. Okay, and then this acronym also mentioned avoid ICE, which is very different from the acronyms before this. So why do they suggest to avoid ICE? Although ICE is commonly used as analgesia and is widely accepted as acute intervention, their theory behind is there is very little high quality evidence that support the use of ICE in the treatment of soft tissue injuries, and they also think that ICE may potentially disrupt the inflammations, angiogenesis, and revascularizations, which all these can result in impairment of the tissue regenerations and also block the collagen synthesis. C stands for compressions. That means intra-articular edema and tissue hemorrhage may be limited by external mechanical compression, such as taping and also bandage. E is to educate the patients. This is a crucial step. So after the first day of have passed, then the soft tissue need love. Okay, this is what they mentioned. Okay, love. L mean loading. So athletes with musculoskeletal injury will benefit from active approach with movement and exercise. So normal activity should continue as soon as the symptom allow for the athlete to do so. Optimal loading without increasing pain can promote repair and remodeling and build the tissue tolerance and capacity of the tendons, muscle, and ligaments. O is optimizations. So bear in mind, as I always mention, the brain play a very important role in recovery. So barrier of recovery includes psychological aspect, example, catastrophications, depressions, fear. Okay, so research show that this factor may explain the variation in symptom and limitation after ankle sprain than the degree of the pathophysiology. Okay, so patient athletes which is pessimistic will actually influence the outcome and prognosis of the injury. So what we have to emphasize is have to encourage the athletes to be optimistic, but at the same time to stay realistic and in order to improve the chance of optimal recovery. B is vascularizations. That means musculoskeletal injury management usually need to include cardiovascular physical activity. Although more research is needed in this specific to what extent the cardiovascular respiratory fitness required, but pain-free cardiovascular activity is a motivational booster and can increase blood flow to the injured area. E stands for exercise, which is evidence has shown that using exercise therapy in the treatment of example, ankle sprain can reduce the risk of recurring injury. And exercise can also improve the mobility, strength, proprioceptions at the early stage of the injury, and avoid pain to promote optimal repair in a subacute phase, and always use pain as a guide to progress exercise gradually and to increase the level of difficulty. Okay. Okay, I think I will skip. So, okay, some other beside the ICE, price, and then we move to police, peace and love. Other things that we use, including in the phase one of rehabilitation, includes the electrotherapeutic modality that I have mentioned, and then medications, anesthesia, muscle relaxants, especially NSAIDs. We try to avoid unless it's the patients having a very high experience, very high pain score, then unable to even execute the rehab plan, then we have to give. And then sometimes if the patient experience muscle spasm, then we can actually give muscle relaxants. And then the third one is the therapeutic exercise, depends on the type of the injuries. And then always maintain the power, strength, endurance of the unaffected site, and then maintain the cardiorespiratory fitness. Then we move to phase two, which is the immediate or the restorative or the recovery phase. Usually lasts from day 5 to 8 to 10 weeks. The goal is the same as the phase one, with the addition of initial progressions. We're starting to add on some range of motion exercise and strengthening exercise. We can start with isometric strengthening, which doesn't, if the patient unable to move the joint, okay, and then later we can progress to isotonic or even isokinetic. And then we also try to restore the functional loss, example, to restore back the gaits abnormalities. And the management that we employ include the one similar to the phase one, like the pain modalities, therapeutic exercise, and then we'll add on to maintain the muscular strength, power, endurance, and also don't forget to maintain the cardiorespiratory fitness. And then the phase 3, which is also called the advanced or the sport-specific and functional, or sometimes they call active rehabilitations or remodeling phase. In this phase, the goal is the same as the phase 2. With additional, we try to regain the full range of motions, and then to improve the strength, endurance, and neuromotor control, including the proprioceptions. This is important to prepare the patients for full functional activity later. And also in this phase also, the physio or the physician have to introduce the sport-specific functional training until the patients can actually perform those activities, those trainings without any symptoms. Okay. So the phase 4 is the return to sport phase. Okay, so this phase actually lasts from day 21 to sometimes, depends on the type of injury, can last until 6 to 12 months. Okay, and the goal is the same, but the main aim here is actually to safely return the athletes to participations, and then to sport, and then to performance. Okay. And always bear in mind to able to meet the sport-specific functional demand physiologically and psychologically. Okay, so this is what happened when an athlete is trained when during the recovery phase, when it's not fully recovered yet, the the athlete still sustain the injury. So the strength and endurance is actually below the optimal level. So when the athletes train, he will go, most likely will go into fatigue, and then when the exercise stop, he are unable to fully recover to the baseline strength endurance level, and then there will be more injury occur, and then that will end up in overtraining and injury. Okay. On the other hand, if we manage to maintain the athlete's strength, endurance, and also the cardiorespiratory fitness, so when the athletes is started training, okay, the fatigue level will actually require quite fast to the baseline level, and then the exercise will go into the adaptation phase, and then this kind of training will actually bring the athletes and will train the athletes to become more adaptable and become stronger. Okay, the last phase is the re-injury prevention phase. It's actually the continuations of a specific training tactic and drills. So this re-injury prevention phase is actually like the secondary preventions in sport injury. It's actually the targeted individual strength and conditioning exercise. This phase usually is taken by the strength and conditioning specialist. The aim is actually to optimize the function and the performance and to prevent the occurrence of the re-injury. Okay, so some of the program like the one that I mentioned, the FIFA 11 Plus, can be actually used in this phase. Okay, the last few slides. So in each of the phase, we have the goal that we want to achieve, and then usually the therapeutic exercise or the modalities, and then we have the criteria to progress. So for each of the stage, we have to make sure the athletes achieve the criteria to progress before we move to the next stage. Otherwise, this will actually give a detrimental effect to the injury and also cause more harm. Okay, don't forget to also monitor the progressions. The progressions can be monitored either through objective measures, the performance, physiological or biochemical, or subjective measures like mood disturbances or perceived stress. Always remember to the training loads have to be monitored by accurate and easy to interpret feedback, because this is important to enhance the knowledge of the training response and to help in designing an effective training program that will actually eventually enhance the athlete's performance. Okay, the last two slides. Okay, this is the progressive models of rehabilitations. So we always remember to tackle the first is when the patients come to you with injuries, we will ask from the history, the mechanism of injury, the durations of injury, and also how does what is the pain score and all the other history relevant to the injuries, including the drug history, the family history, and social history. Okay, and then we will move to the most bottom sides of the pyramids, which is the physical examinations. After the examinations, then we'll come to the diagnosis, and then the phase one of the rehabilitations involve the swelling control, the pain control, and we try to protect and restore the integrity of the injured tissue. After that, we will slowly move up to the phase two, which is restoration of the range of motion. And then at the same time, we restore the control of the volitional contractions. Then we move up. After the range of motion is achieved, then we only will move to strength and conditionings, okay? And then we try to restore the reflex reactions. And then later we will restore the control on complex functional activity. This is the phase 4, the functional or sports specific activities. And then phase 5 will be return to after return to function activities, then we will return to participations, return to sport, and last but not least, return to performance. Okay. And the last slide here is actually, I just want to introduce this, the START framework. I think this is very famous for return to play decision making. So this is actually a 3-step return to play framework that actually involve step 1, evaluation of health status, step 2, evaluations of the participation risk, and step 3 in decision making, decision modifications. So this framework is actually a group of factors that are responsible for return to play according to the sociological source of the informations from the medical factor, okay, from the sport risk modifier, and also from the decision modifier. So for the first 2 steps, assess the risk, and the decision to return to play is actually based on the interaction of this risk with other factors that affect the patient's overall well-being, which is the decision modifier. So when you consider return to play, you have to consider all these 3 steps and also all these different modifier. Okay. That's my last slide. I think I will skip this video.
After ACL surgery.
Okay, so this is all my reference, and I really apologize for taking so many extra times, but I actually welcome any questions, and thank you so much.
Thank you, Dr. Alston. I think we don't have any question. So if I may continue, thank you again, Dr. Alston. You are correct. Although this is a broad topic, you were able to condense it into 2.5 hours. We learned a lot from your presentation, particularly about the neuromuscular training program, protective equipment, the standard stretching protocol, the lower extremity injury prevention, nutrition strategies, sports rehabilitation team, and the phases of rehabilitation. This is indeed a topic worth discussing. At this moment, may I call in again Dr. Jewelson Santos, the IAPES President, to award the certificate to our resource speaker.
Thank you so much, Dr. Alston, for this opportunity to have you. And you have really shared a lot of interesting topics and insights that would be greatly needed and can be adopted by our participants for today. So let me award this certificate of appreciation. Let me read the citation. International Association of Physical Education and Sports Incorporated present this certificate of appreciation to Dr. Alston Choong for sharing his precious time and effort as resource speaker during the conduct of the international webinar on the integrating medicine and science in sports injury prevention and rehabilitation, organized by IAPES, given this 24th day of July 2021 via Zoom, signed by our country coordinator, Professor Mary Jane F. Pernitas, our country head and representative, Mr. Limbel O. Abellanida Jr., and yours truly, Associate Professor Dr. Julson M. Santos, the President of IAPES. Once again, thank you so much, Dr. Alston Choong Wan Kwong, for this opportunity that you have given us to know you and to get a lot of information on this topic that you have shared today. Thank you so much, Dr. Alston.
Thank you so much for having me and also presented me with this certification of appreciation. Thanks, Prof. Jeffersons, and also the organizer. Thank you so much. I have left my email at the chat box, and also I also just give me a short times. I just want to share that my associations, Malaysian Association of Sport Medicines, we are organizing International Sport Medicine and Exercise Science Conference on 11 and 12 September. So you can actually type the link which I already shared in the chat box to view the conference website for registration and abstract submissions. Yeah. Thank you.
Thank you, Dr. Alston. We will be happy as well to endorse the conference. So we will be helping on the promotion of the conference, Dr. Alston. Thank you so much. Sir Vince?
Okay. At this time, please be advised that in order to receive an e-certificate, you must accomplish the feedback form. The feedback link will be visible in the chat box. Okay, at this moment, may I call in Professor Dr. Jesus Argarin, Professor from the University of Makati, for his concluding address. Sir.
Thank you, Sir Vince. Now, I would like to take this opportunity to thank the President of the International Association of Physical Education and Sports Incorporated, the innovative, energetic, and workaholic Dr. Jefferson M. Santos, to the Chief Advisor of International Association of Physical Education and Sports, Dr. Kishore Makapajay, to the International Advisory Board and the International Association of Physical Education and Sports Incorporated, member Mr. Sobrata D, and to our distinguished speaker from University of Malaya, an expert, a practitioner in sports medicine, Dr. Alston Choong Kwong. I am pretty sure that all the participants are enlightened by our topic for a lifetime. The sports injury prevention and rehabilitation is essential for physical educators and coaches, that we are as PE teachers and coaches now. At the same time, know the scientific approach on how to prevent injuries to our young athletes. Let me just again emphasize the benefits of having knowledge on how to prevent and the importance of treatment of injuries of our athletes so that we can improve their physical health and that they can perform well during trainings and competitions. I'm sure most of us are excited to apply everything we have learned here today. But since there is still this pandemic, we have limited access to sports, but I am also sure that we will not forget everything we have learned here today for the near future use. Let me end this with my favorite phrase. The pain you feel today will be the strength you feel tomorrow. Thank you to all the participants who are here today with us. Congratulations to all, especially to the organizers. Job well done. Hope to see you again all next webinar. Thank you, sir.
Thank you, Dr. Argarin. Now,
Thank
may I
you, Sir
present?
Vince.
Yes, po. Now, may I present to you Mr. Eduardo Lugto Jr., a faculty member from the Cavite State University, for his vote of thanks.
Thank you, sir. To our coordinators and to our worldwide participants, I deem it a great honor to propose the vote of thanks to all of you have helped us in making this webinar such a success. First of all, I would like to gratitude Professor Dr. Joelson Santos, the President of International Association of Physical Education and Sports Incorporated, to the respected Dr. Kishore Mukhopadhyay, Associate Professor at Union Christian Training College and Chief Advisor of International Association of Physical Education and Sports Incorporated, and to our beloved Mr. Subrata Day, member of International Advisory Board of International Association of Physical Education Sports Incorporated, for gracing today's webinar. Thank you very much. And I must mention our deep sense of appreciation to Dr. Alston Choong, sports and exercise medicine physician in the University Malaya Medical Center, Kuala Lumpur, and also lecturer of Sports Medicine Unit, Faculty Medicine of University of Malaya, and Honorary Vice President of Malaysian Association of Sports Medicine. A big thanks also to Dr. Kwang for your effort towards integrating medicine and science in sports injury prevention and rehabilitation. We are all inspired by your great words, Dr. Kwang. We also like to express our thanks to Professor Dr. Jesus um, Argadin of University of Makati, as he has capsulized the salient ideas of today's webinar. Finally, we would like to take this on the record, our hearty thanks to this event's moderator, Mr. Vicente Rabang Jr., teacher from Punta Integrated School. To our participants, ladies and gentlemen, an event like this cannot happen overnight. The wheels start rolling weeks ago. It requires planning and a bird's eye for every detail. We cannot thank everyone enough for the involvement and the willingness to take part on this event. In behalf of IAPES, the International Association of Physical Education and Sports Incorporated, let us continue our passion for excellence. We shape the world of physical education and sports. Thank you and keep safe, everyone.
Thank you, sir. At this